All right. We'll be starting now. Thank you for joining us today. We're very happy to be here. My name is Dr. Iseko. Today is
Dr. Awofisoye.
Dr. Awofisoye. Thank you very much. Dr. Awofisoye is the guru of peripheral artery disease. And Dr. Dafe is with us also. Dr. Dafe, gentleman from Port Harcourt, and we're also discussing a co-discussant with us. Dr. Dafe, can you say hello?
Yeah, hello. It's wonderful to be here.
All right, thank you so much. So we'll be starting almost immediately. Thank you all for joining. We have over 50 people present and more people are joining. Remember that you can catch up these sessions again afterward on the YouTube page. And we will also send you the slides and we will send you the link so that you can join up with us subsequently. So this cardio care, this is where we work, where we are broadcasting from predominantly, except one of us that is out of town. My name is Iseko, like I said, Dr. Awofisoye is me, and Dr. Dafe is joining us virtually as well. So we're talking about peripheral arterial disease, and it's a very, very, very important topic, in clinical practice. Like I said, we are support hospital in Abuja, 90 minutes from anywhere in the country. We're flagship specialty hospitals, founded in 2016, but it was founded in 1982. And our hope is to help support in cardiovascular medicine and reverse medical tourism. So the objectives are essentially to refresh our knowledge, to improve our ability to screen and identify people with the disease, to improve our capacity for management, to know who needs to be referred, to evaluate people, that have peripheral artery disease. So, Dr. Awofisoye, maybe you can tell us something about definitions of peripheral arterial disease.
Absolutely. So, peripheral arterial disease, I'm sure we've all encountered patients with these conditions before, and it's a disease of the peripheral arteries. When we say peripheral arteries, we mean the arteries, arterial system of the body, excluding the coronary artery that supplies the heart, and especially also excluding the cerebral arteries that supplies the brain. Of course, it excludes the pulmonary artery of the lung as well. Any time that there's a disease, stenosis or occlusion of those arteries on the aorta, especially of the limbs as well, peripheral arterial disease. And we know that it's mostly due to atherosclerosis. This causes stenosis and also blocking arteries. And the truth is that this is the leading cause of thrombosis. This is the leading atherosclerosis is the leading cause. You can also have thrombosis, embolism, vasculitis, but the vast majority of what we see is from atherosclerosis. And the leading risk factors for this, as you can guess, it's hypertension, diabetes, sometimes, when it comes to hypertension, diabetes, and as well.
Exactly. So, peripheral artery disease is very, very important. A lot of the patients we are seeing in Nigeria, the epidemiology is shifting. We think that as patients are growing older, as healthcare is getting better, a lot of patients with diabetes, hypertension are coming down with different conditions like this. I hope we're not having too much echo. I hope there's not much. Please put your questions in the chat box. Please put your questions in the chat box for those. Put your questions in the chat box if you have any questions, and then we'll answer it, and then we can see if they have any information for us. So straight going on, no open questions. So going straight ahead, we have looked at the peripheral arterial disease, and I said it's very common. A lot of patients are missed, a lot of issues are missed, people are missed, and people just come with gangrene. We have so many amputees in the country and people that have lost their lives because we must look at peripheral in a larger context. Even though it looks like it's a disease primarily affecting the peripheral vessels, it is a very, very strong pointer of coronary artery disease and other cardiovascular disease. So when somebody has peripheral artery disease, the risk of death from a cardiovascular disease is, tremendous and it's quite high. So it's like you have an external equivalent of what is going on internally. And this is why it's very important. And the vast majority of screening can be almost free and cheap, which so far we know what to do. Okay, so that is essentially what we are talking about in peripheral artery disease. Under this, there's a subsegment we call critical limb ischemia.
Absolutely. And for this critical limb ischemia, there are many things that can tell us there's a critical limb ischemia going on. Now, we don't want this to happen because critical limb ischemia, if you've seen it before, is a terrible condition. Okay, but a patient usually will have pain in the limb. There is often gangrenous change, that's darkening, which can be initially before it becomes more prominent. Of course, many times it leads to ulceration, tissue loss. And one of the key things that can highlight to us that this patient may be having a critical limb ischemia is a patient that may or may not have been having intermittent publication before, but now having pain at rest.
Exactly.
Okay, and it can be often pain at rest. Usually, that patient will tell you that they have to hang the leg at the side of the bed to get relief, and they tell you the pain can be worse at night, not because they're just lying down, but because the leg is elevated, and then the favor that gravity gives that dependent part of the body, it's lost when they're lying down at night. So, by the time a patient has critical limb ischemia, we all have to be worrying around actually, because it's like the limb equivalent of a heart attack. So it's like a limb attack, if you want to call it that. And it tells that there's an advanced arterial occlusion and there is a acute tendency to lose that limb, to don't move very fast. Yeah. So whenever we see rest pain, a patient having pain in the foot at rest, particularly in the most distal part, and then you can have clinical demonstration that there is poor blood flow or poor wounding in there, we should be worried. So that's critical.
So, by the time I get to critical limb ischemia, we must remember that there were several other things that preceded critical limb ischemia. Number one is risk. Patients already have risk. We are seeing them in our clinics, and we must remember that managing hypertension or managing diabetes is not just about managing the numbers. It's about making sure that the absolute risk for cardiovascular disease has been taken care of. Okay, so that's what we are actually checking. So what you check is across the spectrum of this. What you check is across the spectrum of this. And from the patient that has the risk, we keep on checking. We realize that a lot of people may be asymptomatic and there may be a number of issues surrounding this. So start understanding. Once you understand this, then it puts a lot of things. So we know that worldwide is greater than 10% in people above 60s and 70s. Men have more severe disease and are more symptomatic, but complications are more in females. And now we are having a lot of people with advanced medical care here in Nigeria. People are living longer. They are surviving heart attacks. They are surviving strokes. You know, they are now taking drugs and they are getting better for longer periods. So that is what we should be worried about in this situation. Okay, so Dr. Awofisoye, do you have any other thing to say about this?
Well, what I'll just say is that this idea that there's usually concomitant coronary and cerebrovascular disease. And one of the things I like about the peripheral arteries, particularly the dorsalis pedis, is that you can feel it with your hands. I can't palpate the coronary arteries with my hand. I can't palpate the cerebral with my hand. But the dorsalis pedis and the posterior cerebral, you can feel with your hand. And anytime you don't feel that artery, you should be worried. And means you should be worried in terms of you want to evaluate that patient further for peripheral arterial disease formally. And also importantly, you want to assume that that patient probably has coronary artery disease and cerebrovascular disease. So it's a strong marker of ASCVD, even if it's asymptomatic.
Exactly. So we must be careful about this. In Nigerian studies, up to 30% of patients with hypertension have been shown to have this. So we are talking about 1 in 3 patients in our clinics, and our clinics can be busy for hypertension. So it's important to check. And it's much higher in those with diabetes, up to half. That is 1 in 2 patients with diabetes already have an existing peripheral artery disease. And most of these conditions have brachial index. This is something that we can easily do. We already have the blood pressures where you can improvise using the one that obstetricians use for Doppler, although there's a better one for that, and do the ankle index and see that a lot of the patients are asymptomatic. Okay? A lot of the patients are asymptomatic. So most of it is from atherosclerosis, like we said.
Absolutely.
Arterial stenosis, hemodynamics, and all of this.
Absolutely. And because of this occlusion, we know that anytime there's even a slight narrowing of the vessels, perfusion can be compromised. The perfusion can be compromised initially during exertion, just like you have angina. So you have reduced perfusion, which is fine at rest, but by the time the person exerts him or herself, the blood supply is not good enough for the muscles of the leg. And then later when this gets worse, you may not be able to sustain metabolism in the muscles, even in a resting state.
Okay, so we look at this schematic diagram. And as you can see in the schematic diagram, there's as you can see in the schematic diagram, where is my pointer? You can see how it affects, and you can see that there's a lot of narrowing that is happening and progressively before it causes complete occlusion. Now, our job as physicians and as doctors is to make sure that we are able to find this early enough and give appropriate treatment, which typically involves just escalating your regular treatment. You see that some people have called peripheral disease atherosclerosis obliterans. That is like, it is like obliterating the blood supply to distal limbs and end arteries because of this disease. So a lot of time the role of atherosclerosis is multifactorial, but we know we have endothelial dysfunction, we have cell migration that all happens, and inflammation that happens as a part of the tripod. Now, all of these are all happening in virtually just by virtue of age, but also by virtue of diabetes, which has been sometimes considered as a chronic inflammatory state. And then when you put diabetes, hypertension, and hyperlipidemia together with all of this, then we have the nidus for atherosclerosis. Now, atherosclerosis is happening almost everywhere, and it's happening now in a peripheral vessel.
So we mentioned some of these risk factors earlier. Hypertension and diabetes are big risk factors, and we see patients every day. I'm sure all of us here, we have patients that we're managing for both hypertension and diabetes. Smoking is getting more prevalent in Nigeria, and smoking is a huge risk factor actually. Yeah. And also dyslipidemia, inflammation, which can be from any cause, connected to disease. We mentioned that there's some chronic inflammation happening in diabetes. I can think of any other medical condition, especially with inflammation. I was seeing just a moment ago one of our patients who has lupus and heart issues concomitantly. And I couldn't figure out those early specs. I've asked her to do a Doppler scan now. So inflammatory conditions also can actually accelerate this peripheral arterial disease. We have other risk factors as well, which includes thyroid issues, OCPUs, chronic kidney disease, and other things that we know that can constitute a atherosclerotic cardiovascular disease risk factors. And in these patients, we should not wait for them to have symptoms. We should routinely screen these patients for this.
So for all of us on the call, please make sure that you have downloaded some ASCVD calculator on your phone. As a practicing healthcare professional, and especially one that tunes to cardiac care, you should have that calculator on your phone so that you can check your ASCVD scoring for all your patients and document it in their folders. But more importantly is the fact that it just takes a few seconds, a few minutes to check posterior tibial, dorsalis pedis, and add it to your and just examine the skin, examine some of those. We'll go into that in detail. We have this guest, Mr. Jibril, 68-year-old man with diabetes hypertension. He complained of pain and numbness over the last 1 year. And you can see that it's 1 year. Most of our guests are coming with long illness. People are giving them painkillers here and there. Okay, but the pain is worse at night, has only minimal relief from gabapentin that was prescribed by the doctor. HbA1c was 6.7, but a week ago, he noticed darkening of his first and second toe, and he was having some part that was looking like a blister. So let's look at this. I want us to look at the polls and then try and answer the questions. Let's try and answer the question. You have a poll on your screen. Let's try and answer. Make an attempt. So the question is, what factors are here that should have led to an earlier evaluation? What factors are here that should have led to an earlier evaluation? Okay, so 5 people have answered. Okay, that's good. Keep it coming. 25 people have answered. We need more people to answer. Make an attempt. Make an attempt. Don't worry. It's anonymous, so I don't know who answered or who did not answer. Okay, so I'll be ending the poll in 3, 2, and 1. Okay, so let's look at this. A lot of people have said that, okay, diabetes, hypertension, all of the above, none of the above. All of the above is the most predominant, and that is true. We talked about in epidemiology that age is quite important, and as people grow older, the risk for this is higher. Hypertension is also there, diabetes is also there. So that's important information to note. Okay, but what other history is missing here is a good one to find out. What other history is missing here? Can we look at the question? So we have what history is missing from this case review. We have, it says 68-year-old man, he had pain and numbness, glycemic control is good. So what other history was not given in this one that is important so that our histories can show? Okay, I want us to attempt. I want us to attempt.
Let's attempt. I said no negative marking.
Let's make an attempt. So we'll be ending the poll. I can see up close to 30 people have attempted. In 3, 2, and 1. We'll end the poll now. Okay, so we can see the results. And the truth of the matter is that we did not check for smoking. Smoking is very, very important. In fact, we said that it's up to 5 times risk, sometimes even higher risk than diabetes. So it's very important to find out about smoking. And in Nigeria, a lot of people smoke, even though they are not open smokers. Some people smoke, codedly. Okay, then you must remember secondhand smoking is also important. History suggests other cardiovascular disease that they had chest pain and MI, stroke before, TIAs, what were their cholesterol values? And, try to get them, not just to get them, get the cholesterol down, and a foot examination. So these are some things that we should know about this. So these are the history that is missing in this case. So remember, we said it's not always atherosclerosis. So we had this case in cardio care, 48-year-old doctor, remember, 48-year-old trader, hypertension and DM, poorly controlled, no significant smoking, but less alcohol. He had severe pain, coldness, pallor, paresthesia of the right leg. He had a prior history of a beating sensation in his right buttocks. Now, we can already see these places, 48, there's DM, there's alcohol, and these were not poorly controlled. But however, while we thought it was atherosclerosis, what we found in the was quite different. So you can see in this what looks almost like a kidney-like structure, and this is what he was feeling doing boom, in the buttocks. So he had a big ectasia aneurysm-like structure here, from where the clot likely went down and caused the acute limb ischemia. So that was what brought him to the hospital. So it's quite important to remember that atherosclerosis is not always the case, and you should be open to other things. We had another patient, 38-year-old teacher, no hypertension, no TM, no significant smoking or alcohol, had severe pain and numbness for several months. The only history was he had a gunshot which had healed some months ago while on a journey between Abuja and other states in the north. And here's what we saw when we're doing the angio. And if you look at this, you can see the blood supply coming down. If you see my cursor coming down, and you can see right there one of the gunshot pellets, because it was a local gun. So you can see the pellets shattered, and thereafter blood supply acutely here and here, and blood supply diminished and almost no blood supply after this. So you can remember that this are some of the cases that we're going to write out as non-atherosclerotic causes of peripheral arterial disease. So what is the predominant clinical presentation of atherosclerosis? Dr. Awofisoye, let's perhaps do another poll. Yes, so can we try this?
What's the predominant presentation? We have 5 options here.
So is it intermittent claudication, rest pain, ulceration, gangrene, or asymptomatic? What is the predominant presentation of peripheral artery disease? So I want us to try it out. Right? Don't worry, there's no negative marking. I don't know who it is. So if you get it wrong, nobody will crucify you. Okay? I'm seeing a lot of people putting answers in. We've had 30 plus people now. And I think because of time, we'll have to end 32 people, 34. Okay. So getting to 40. All right. Please try, make an attempt. Don't worry. Make an attempt and you fail. You will never fail it again. All right. So I'll be ending the poll in 3 over 40 people. 3, 2, 1, and end. All right. So most people say intermittent claudication. rest pain, and you are right. All of these are all presentations of peripheral artery disease. However, which one is the predominant one is the question we are asking in this case. So let's look at what we have written. 50% are asymptomatic. So most of us got it wrong. 50% are asymptomatic. This is why we're having this problem, this webinar, so that we know that the people that have these problems are not even one in
They don't know.
They don't know. That idea of waiting for intermittent claudication or asking them when they say they don't have intermittent claudication, most of us say, okay, there's nothing wrong with them. They will just come with numbness, with paresthesia, they will come with abnormal sensation. All those are atypical symptoms, and it's quite important to
Well, absolutely. Just to emphasize that it's symptomatic, and that means that most of us wait. In fact, most of us wait until the patient complains before we check. But now we know that in a patient with hypertension and diabetes, make it a routine to assess for peripheral arterial disease. We should ask the patient questions, and we must examine the patient. If there's anything doubtful on that, we need to go do formal investigations, which we'll talk about. It's also important to remember that the intermittent claudication in quotes is not common. That's the truth. Okay, more patients are more likely to present with atypical symptoms that you can mistake as arthritis, as peripheral neuropathy, or as something else that is random. That's just think that something wrong with this patient. They give the patient something cocotamol, something else. The artery is just getting more and more blocked.
So you should never ever write off anybody that has cardiovascular, anybody above 50, smoker, diabetes, hypertensive, you never write it off. And you should never have a full documentation. 1 year you have been seeing a patient with hypertension, with diabetes, that you have never checked the foot, because more than 50% are asymptomatic. In fact, some patients present for the first time with gangrene of their foot, and that is the first time we realize that they have diabetes. So it is quite important that this is checked by all of us. So, and remember that over 60% of those with this have coronary artery disease. So if you have peripheral artery disease, it only makes sense to rule out. So examination is critical because more than half of the patients are asymptomatic. So you are looking at the foot exam, posterior dorsalis pedis, which is here, and posterior tibial is here. The only way you get used to it is by checking. The more you check over and over again, then you can now be sure when it's absent. So this is very important for us to recognize. Keep on checking, so that you can get used to when it is absent. So look at the skin, the shiny skin, there'll be slow healing ulcers,
slow toenail growth. The nails can be dystrophic.
Exactly.
Okay? And then it's important to also be able to now measure the ankle index, and in some cases the toe index. Importantly, like we said earlier, people above a certain age, above the age of 55 years old or above the age of 50, especially with hypertension and diabetes or peripheral disease, we must examine their feet.
Okay, so the textbook intermittent medication is uncommon. So if you are waiting for that to say the person has it, you will miss out a lot of patients. It's very painful for you to be the patient's family doctor, see the patient for 5 days, and the patient still comes down with gangrene. It is a stain on your care. Okay, so look for critical limb ischemia, rest pain, coldness in the feet, especially at the night when the leg is not dependent. And remember Leriche syndrome, where it is not, you have an autoarea confusus, which is happening high up, and in this case, there's a classic triad. We may not always see this of claudication, impotence, and femoral pulses are absent. So in this case, even if femoral are absent, the person comes with impotence, you should also look for this and be sure that we need to intervene as soon as possible. Because if this gets to critical, it can be disastrous for the entire limb. Okay, so we'll go on. So can you talk about this spectrum of peripheral?
Absolutely. So we did mention earlier that a lot of patients may not have symptoms. Now, when they do have symptoms, it can go along the spectrum. And we've talked about pain, ache, tiredness. Sometimes they say that they cannot walk far. They can't pinpoint the reason why they cannot walk that far. They can also have they can describe it as numbness. Can also have those intermittent symptoms that we classically say is intermittent claudication, and that can range from mild, moderate to severe. So by the time you are having a patient complaining of breast pain, you should be worried. In fact, you should not go to sleep on that. And is having pain that is due to arterial disease at rest. Okay, for patients that you know that have peripheral arterial disease, you should take all measures to make sure that the patient does not have any wound on that leg, because the chances that the wound is going to heal well is slim.
Very slim and very poor.
And then anytime you see a patient with poor wound in the leg, irrespective of diabetic status, irrespective of hypertension status, you must make sure that you've assessed the vascular supply of that leg and you're sure that the leg is doing very fine. Now, by the time we see benign or overt gangrene, I mean, that's very bad already, even though, of course, the patient can still benefit from intervention. But we are hoping that we can before there's an overt gangrene. So that's the spectrum from mild to severe that we can have. That's worsening flow limitation in this.
Okay, so it's very critical, and we can ask ourselves, is it neuropathic or ischemic?
Yeah,
now,
John.
there's an overlap.
I want to talk about this because many patients with
Okay, yeah, Dr. John.
are passed on wrongly that they have peripheral neuropathy. And we can see the case we described earlier. The patient was given gabapentin. A little bit better, maybe, but the stuff is still there. So we as clinicians, we need to be able to separate peripheral neuropathy, which is extremely common in diabetes particularly, from the one that is distant.
Now, if a patient should sue you, having lost their limb and having you taking care of it, and you don't have this documented, that supported your decision for one line of approach or the other, you may be liable. So it's something that you should really take note of.
The description of the symptom is actually quite similar. Both of them can be numb, both of them can be aching. If you have pains and needles, it supports neuropathy more, but it's not always that useful. But what is often useful is that for people who have neuropathic pain in the leg, particularly peripheral neuropathy, it tends to be worse when they are resting. It tends to be better when they are walking around. Whereas walking worsens.
The issue is that what is
Dr. Daffy, are you saying something? Dr. Daffy, are you saying something? Okay, try to speak.
So walking typically worsens ischemic pain, whereas resting improves the pain of ischemia, whereas it worsens neuropathic pain. So that is ischemia is often worsened by walking and improved by resting, whereas it often is reversed for neuropathy. But irrespective, anybody that you imagine or you think has peripheral neuropathy, please ensure that you can feel the pulsations well in the foot. Now, the good thing about peripheral neuropathy is that many times it's also with bounding pulses, which is about the opposite of ischemia. By the time you're not sure you can feel the pulses very well and you think they're weak, please do a ankle brachial pressure index for this patient and then get a Doppler ultrasound scan to confirm. At that time, that's why you can put your mind at rest that confirm that blood supply is good.
Okay, so and this kind of helps you. If you are thinking it's also iliac, it's buttock, and he keep just like the patient we tried to present earlier, I had that aneurysm that was having problems with buttocks. So sometimes they're having it in the thigh, upper to thirds. Now, the higher you worsen, because when anything happens, you have much more tissue loss. And it's very disheartening to see people that come in very late, calcified vessels, very little hope for endovascular intervention that we could have taken care of much earlier. Let me see if there are any burning questions in the in the Q&A. If you have any questions, please put in the Q&A so that we can answer it. So when you are seeing foot claudication, you are looking at tibial and peroneal arteries. When you are seeing the lower tail of the calf, popliteal, upper tail of the calf, SFA, in the thigh, and from the thigh upwards, you are looking at autoiliac. And this now requires more extensive intervention. The last case we did in the cath lab, we had to do a brachial access, so coming from the arm to be able to get down.
Because of serious occlusions.
I'm telling you, to be able to get down to the aortic roots, with the aortic bifurcation to the iliac vessels, to be able to get across to it. So it's quite important that we recognize this. So if you look at the presentation of cases, most cases are in the femoral and popliteal region, most cases, but you still have 50% in the tibial, femoral area, and then also iliac presentation in this case. And Dr. Dafe, if you want to speak, just let me know or raise your hand so that I can see, because I can't quite hear you. So that somebody can notify. All right, so when you are evaluating, can you talk about this?
Talked about this earlier. We should be aware of the risk factors. We've talked about that over and over again now. And then when we see the foods, immediately a patient with diabetes, hypertension, smoker or older patient enter your office, as far as you measure the blood pressure and check all the other things you check, tell them to take care of their shoes and their socks, not just one leg, but the 2 feet.
In fact, teach them so that even if they're not coming to you, wherever they are going, they will tell any doctor, please, doctor, check my feet.
So by the time you see the foot, even before you stand up, you can see some of these things already. Thin skin, smooth skin, shiny skin, a leg that is looking a bit pale or dusky. Okay, whereas by the time you're seeing hair loss, thickening or dystrophic nails, you're getting worried. Okay, and make sure you touch it. Okay? Touch it, examine it. By the time you get coldness in the extremities, you're worried. Okay, and then make sure you palpate the vessels as well. Like we said earlier, things like ulceration and gangrene and leg changes. There are often signs of poor care earlier. Okay, and if there's going to be ulceration or gangrene, it's typically at the tips that suggests that's at the tip of the fingers that suggests that due to a vascular impairment. It can be wet, it can be dry. The dry ones actually have some sort of a slightly better prognosis because sepsis usually quite less. And of course, you can also check for a bruise there, and also there's this Bogas test in which when you elevate the limb, you tend to get poor perfusion. That's capillary flow can be quite impaired, which can also tell you that perfusion is impaired.
I think you are doing the 5 P's. I am looking for the 5 P's. You are carrying most likely dealing with acute limbs. So in most of the patients with atherosclerotic disease, diabetes, a lot of them will have these other changes coming in subtly. But most of the patients with acute limb ischemia, that is, they have a shutdown almost immediately, that they have this, they need to get from the vascular treatment as in within minutes to hours. So by the time you are waiting for pulselessness, paralysis, paresthesias, you have already waited through.
I remember a client that we saw about maybe up to 6 months ago, just right almost within 12, 24 hours, right in front of our eyes, our limbs changed color.
Yeah.
It was a sad sight to see. So I think emphasizing that once there's acute limb ischemia, you want to actually intervene.
Okay, now I will really ask about the risk factors. I will really ask about the risk factors. I want to play something for you and to see whether we are really asking about the risk factors.
Hopefully, by the time we're done watching this, it would enhance our accent rates.
Although this is a can they hear it?
Okay.
Anyway, we'll have to move on then. Okay, so there is this staging of disease in this case. But remember, we said 50% are asymptomatic. So even though they are asymptomatic, they still have severe disease. So this staging has different uses in terms of prognostication, but not as per diagnosis or whatever what it is. Are we lost?
Hopefully they're not.
Okay, so let's continue.
So just ranging from asymptomatic, by the time there's rest pain, you know that you're in stage 3, and then that means you should be really worried. And by the time you have stage 4, it means there's some ulceration and severe ischemic ulcers or gangrene qualify for stage 4. And definitely, by definition, all this from stage 3 and 4 Fontaine translates to stage 4 to 6 of the Rutherford qualify for intervention. Now, for people who have claudication, you need to put that in the context, but definitely medications need to be optimized and the patients need to be considered for intervention as it needs to be assessed for patients for the intervention.
So we'll give you a very summarized one slide. I'll show you at the end of this presentation. That will help you just know what to do for which case. But just know that people are having severe claudication, they have bad ABPIs or rest pain, they should, at that point in time, you should make sure that you are assuming you have optimized medical therapy before then.
And the patient should be seen by an interventional cardiologist and assess
exactly.
So
the other thing that you must do as a minimum, in this case. Okay, so the other things you must do as a minimum, blood pressure, lipid profile, blood sugar, HbA1c, and this you must look at it like as if you are seeing the tip of the iceberg whenever you are sick. So you must use the opportunity to review all the possibilities around cardiovascular disease, check their ECG, check signs of ischemic heart disease, check their hypertension control and all of that. That's quite important in this case. I hope you are hearing me. If you are not hearing me, let us know. Is there any problem?
Actually, so we have differential diagnosis. We've already talked about neuropathic pain, which is a very big indicator of peripheral arterial disease. In fact, I dare to say that peripheral neuropathy is the biggest enemy of peripheral arterial disease, because most doctors will just say, "Oh, you have pain, oh, it's peripheral neuropathy. Take this pregabalin, take this gabapentin," and then they go to sleep. Okay? We should also be mindful that spondylosis and radiculopathy, which can give symptoms at any length of the limb, any part of the lower limb, can present like this. Osteoporosis sometimes can give some patients pain, particularly they have collapse of the vertebral column, arthritis, spinal stenosis, and DVT.
Now, I want to talk about arthritis. The fact that the patient has arthritis does not exclude them from having peripheral disease. So sometimes people have arthritis, and because of the arthritis, it masks every other pain. Every time mama comes, mama says the arthritis. You twitch when mama says the arthritis, and then you give her, you tell her sorry, instead of assessing that patient for peripheral disease. So the fact that these are there, it doesn't mean that they cannot coexist. And it's very important because the same age range that you carry have osteoarthritis will also be at risk for a lot of
anytime you diagnose anything, if you attribute any pain in the lower limb to any of these things, please make sure you check the heart rates and make sure that you are satisfied that perfusion is good in that limb. So all these things can mimic it.
All right, so the test typically an ankle brachial pressure index. And what does ankle brachial pressure index?
So the ankle brachial pressure index is something you can do at the bedside, and it entails measuring the blood pressure in the arm and also measuring it in the leg as well. You measure in the two arms and you take the higher one, and you also measure in the leg by occluding the arteries at the level just below the calf and use a handheld Doppler to assess for pulsation. So that will tell you where the systolic is. Technically, you can almost use the stethoscope to pick the systolic as well, but it's not as accurate as the handheld Doppler. And the handheld Doppler is close to the sonicate, what do you call it? That's stuff that they use
for checking fetal hearts.
Absolutely, that they used to check fetal hearts. So it's close to that, but the one we use for arteries is quite a little bit more sensitive. So the pressure you get in the upper limb, the higher from the upper limb, you put as the diastolic, and net correct the slide. You put as the lower one, and the one for the lower limb is one you put up and you interpret it. Normally, the one in the lower limb should be higher. But by the time you have any reduction in that, you calculate the ratio as stated here. So normal, you should have it straddling around 1. But by the time you are having a reversal of that, in which the pressure in the lower limb is reduced, that's because of impaired perfusion, then you are knowing that you are having some peripheral arterial disease. So again, normal is between 0.9 and 1.3. By the time you have anything less than that, there is peripheral arterial disease. And the proportion to which it is tells you of severity. Sometimes you see patients with less than 0.4. It's those patients most for vascular assessment.
Okay, so fine. You can see, so take the blood pressure in the lower limb over the blood pressure, higher of the blood pressure in the arms, and then you look at it. So it's quite simple. The other things you can do: Doppler ultrasound, transcutaneous oximetry, stress testing, CT angiography, and conventional angiography, most of which can be done here in our center. So you can always refer, because this is a center of excellence for peripheral vascular disease in care and management. So these are all things that you should consider doing. But remember, this ankle brachial index everywhere, almost every village in Nigeria has Doppler for obstetrics. So, and they have suites. So it means it can be done at the primary healthcare level. Even as a basic, you have the history and you have your ABPI, and to a large extent help you know which patient needs to be referred and what should happen next. So that's what we are talking about. So in ultrasound, you heard the ultrasound to define anatomy, and you use it to, and it has a very high sensitivity, especially in very good hands.
Yes.
Okay, so you now have, start the obstruction, it becomes biphasic, and then exactly so the normal triphasic, and then subsequently becomes monophasic. By the time you're getting to monophasic, it's typically could indicate some level of severity. And then Doppler studies, can help estimate stenosis in some cases. But even though once you are able to have an abnormal Doppler or duplex ultrasound, just know that at this point you need to be considered. Now, stress ECG, or stress test.
Stress test can also be done for this, just as you can do it for coronary artery disease. It's often not done routinely, okay, but just so that it can be done. And we do offer stress tests, especially for coronary and cardio care. And this is a picture of someone undergoing stress test, which should be done in patients with suspected coronary artery disease.
But also in this case, and the reason in this case with peripheral artery disease is that you first do the baseline, I mean, ABPI followed by you use a normal protocol, or even just do a continuous protocol. That way you can characterize their baseline pain-free walking distance, their peak walking time, and their maximum distance walk. You cannot use this as a way to follow up the patients and be able to create improvement, especially when you are doing medical management. You can also, characterize the impact of medication.
Absolutely.
And then you can, so if you do the post-exercise measurement of the pressure, arterial pressures, the pulse volume, and the ABPI, it often drops in peripheral artery disease, and this can help you to some extent differentiate. So you can add that to your, so if just a normal treadmill, people are walking graded or normal for a normal speed, and you can do your ABPI before and after. And then also,
and it can also help you judge the success of whatever medical interventions you're doing,
correct,
and knowing whether those patients are sent for advanced intervention, including angioplasty.
So if you have been managing a patient conservatively and you're not getting improvement in your painful walking distance or distance walked and or symptoms, then you should almost certainly know that you need to get endovascular assessment. Okay, so CT is also good, non-invasive, contrast is there, typically for patients with atypical symptoms, and also it is quite important, it's widely available, okay, and in some cases, you typically will have to give contrast, but in some cases, we weigh between doing CTA and invasive. The reason being that because you are giving contrast in CTA, if you know that you probably have to intervene or to confirm it on the invasive, you may want to minimize the amount of contrast and radiation you're giving.
That means going directly to the invasive.
And going directly to the invasive. So this is the the conventional angiography, how it works. Let me see. I think yes, we have a video there. So we kind of put puncture the artery in a manner. Typically, we go the opposite side, retrograde, so yes, like this, and then we take it across to the other side till we can see where the blockage is. And if there's a stenosis, we can easily stent or put a balloon there and restore blood supply. So the good thing about invasive and endovascular is that at the same sitting, we can correct any abnormalities seen. So quite important in the care of this. So this is how the cath lab looks, and then what we do.
Investigations are also important in patient peripheral arterial disease. Don't forget we said earlier that in these patients, there are a bundle of ESCVDs. There are things going on, there are things likely going on in the brain, and then we don't just want to sit on the limb and I've heard of patients being managed before and they're managed for peripheral arterial disease, and the patient had a heart attack somewhere around that period of time. Why? Because there's something else that was going on in the heart that was not very evident. So you need to make sure that this patient gets ECGs, echocardiography. You need to check their carotid artery, which is amenable to check by ultrasound scan with a Doppler. And in some patients, coronary artery calcium score can be done, and we should consider such patients for coronary angiography. Can patients in which you can pick that they also have things that suggest ischemic heart disease.
Even if you are managing conservative for peripheral artery disease, make sure that you rule this out, because you may want to manage conservative for peripheral, but you know that the coronary artery disease may be very lethal very fast. So you may want to almost greater than 70% of people with peripheral artery disease have coronary artery disease. In fact, it is called peripheral artery disease, called the coronary artery disease equivalent. So once you have it, you are almost sure that something is happening in the heart. Okay, so there are a number of algorithms. I will not spend time on that. I'll talk about it later. The management involves stratifying the risk. There's some conservative management, manage other cardiovascular risk, revascularize, and unfortunately, in some cases, ablative limb surgery. Okay, so how do we do stratification?
So we should understand that. So we have patients, we talked about these categories before. So some patients are asymptomatic, which is possibly the milder end of the spectrum, but they still need some treatment. Some patients will have intermittent claudication, and then some patients will have this chronic limb ischemia. And by the time the patient is having this severity of limb ischemia, in which is persistent rest pain, patients that require analgesia for the pain,
exactly.
Patients that have a very bad ankle breaker index, irrespective of the breaker index, in which the pressures in the artery. Don't forget that your systolic blood pressure in your upper limb is usually around 110, 120. In the lower limb should be higher. But if you're having an ankle pressure less than 50, there's almost no blood supply going to that limb. And those are the the most high risk category of patients. Don't let me say the term worse. And those patients must be seen by an interventional cardiology team.
So, irrespective of the fact of the endovascular therapies or not, you must make sure that conservative management is ongoing. And this is important all through the case. So, risk factor modification, make sure the blood sugar is well controlled, cholesterol, statins, antiplatelet therapy. In most cases, dual antiplatelet or antiplatelet and an anticoagulant may give very good results in patients with demonstrated severe disease. So we're talking about using low dose rivaroxaban or apixaban, clopidogrel, or even sometimes we get to use, but please do that only with specialist advice. You get to use aspirin, clopidogrel, and rivaroxaban at their specific doses, but only with specialist advice, and then statins. Now, there are other things that do help. Pendoxifilin and silostazole and could also be quite important in the care of in this conservative care. But remember that silostazole has, even though it is quite good, it has some problem in terms of sudden cardiac death in a lot of patients. So really make sure you have screened your patients very well so that you don't start treating something and cause harm.
And it's only the main benefit is more of symptomatic improvement in terms of pain, not necessarily reducing gangrene rates at all. So physiotherapy and exercise training is also important in those patients, but it has to be medically prescribed based on how much occlusion the patient has, must have checked the coronaries, and then it's part of their rehabilitation. Apart from that, there's a role for analgesic for pain, and of course, foot care is also important as well. Now, we know that in patients with maybe pedal or something you want to elevate, but in this kind of patients, we should not elevate the limb because elevating the limb would further impair blood supply a bit, and they're likely to have more pain. So some patients actually have to lie down, dangling their legs by the side of the bed so that gravity can push a bit more blood supply for them.
By the time you're getting to that point, remember that you should already be considering endovascular therapy, and it should really be that insurance does not cover it or cost a big problem for you to be doing only this at this point. Okay, the typical progression, most patients remain asymptomatic. Some patients, the cardiovascular mortality from related diseases, which should have been checked, may cause their mortality. And a lot of some other ones progress over time to rest pain, tissue loss, gangrene. And it is more likely to progress if the person is older, if they are smokers, and if they have diabetes. So there is absolutely no reason not to be aggressive in patients with diabetes because the risk of progression of this disease is quite higher, and those that are smoking. So they must stop. So if you look at it, you can assess the cardiovascular risk factors, modify the risk, make sure your LDL gets less than 100. But of course, this has changed of recent. We are talking about LDL less than 50 in some cases, so not or 70. It used to be 700, it got to 70, then to 50, and now most guidance are saying get the LDL as low as possible. So you need to think what it should never be above 100. That's bottom line. HbA1c comes down, blood pressure is in, antiplatelet therapy, statin therapy. Now remember that the statin therapy is not just for the cholesterol lowering. So cholesterol is low, don't just take it off because the statin stabilize plaques, they reduce inflammation, has some anti-inflammatory properties, and also help general care. So then you can assess with your treadmill, your walk distance, your exercise, which is a quality of life questionnaire to check and see whether you need to go further into revascularization, angioplasty, and the like, especially those that don't have clear-cut critical limb ischemia. So we have this task classification that we use for femoral and popliteal lesions. Dr. Dafe, I've not heard your voice, so I don't know if you're still around. That's the time he was trying to talk.
Sir, I'm here. When I get to the cases, I will talk, sir.
I can't hear him, though.
Can you hear me, sir? Can you hear me?
Yes, I can hear you.
Yes, very good. I said when I get to the cases, I'm going to talk. You are
okay,
and Dr. Awofisoye, I'm really enjoying the discussion.
All right, great.
Yes, sir. Thank you, sir.
All right, great. So we'll continue. So the TSC classification of femoral and popliteal lesions, I'll not bore you too much with it, but when you get the slide, you can just go on with it. And it's just about deciding whether endovascular or surgical therapy. So these are the patients that you are already referred to our center or to a peripheral vascular, a center of excellence for peripheral vascular disease. And then we now decide if we go for surgery or not. And then we now use this classification to be able to determine length of vision and all of that. So in most cases, we have to combine both conventional angiography, CT angiography, Doppler, and then the patient care, do a lot of multimodality approach, multimodality imaging to be able to arrive at what is the absolute best, give the patient the best outcome with minimum issue. Okay, so
if you have any questions, please put them in the Q&A box. We'll take them along the line.
Yeah, somebody asked, can Raynaud's disease cause PAD?
Classic Raynaud's disease is some sort of vasculitis. So typically, it doesn't cause what we will call PAD because it typically affects more of the smaller arteries, usually in the hand. But it's some sort of peripheral arterial disease actually.
By definition, technically, it's a peripheral arterial
disease. And it can cause gangrene, usually
yes.
on the finger. Yes. So technically, it's a peripheral arterial disease. So I think I will have to agree with that.
Yes.
And now, how do we differentiate the features of peripheral arterial disease from
aging?
Well, I
follow what we have said. If the person is aging and they have peripheral, you must still check for the vessels. If you cannot feel the distal vessels, whether they are old or not, they have peripheral disease. You should be able to do the ankle brachial index, the toe index, and consider for ultrasound. Once you begin to have those symptoms of critical limb ischemia, you should begin to consider therapy, not just
so. Peripheral arterial disease is totally different from aging. It's just that peripheral arterial disease is more common in people that are older. Okay, so irrespective of someone's age, if they have peripheral arterial disease, we should give them the evaluation and treatments that they deserve. Of course, to people that are too frail, we can say they are too frail to receive treatment. But we should not allow people to lose them because they are older.
Somebody said, can you share recordings? Yes, all the recordings, the email you should register, the recordings will be available to you, and the slides also be available to you for your easy reference. When you get the slides, please share far and wide with your colleagues so that they can benefit. And please try and invite somebody for the webinars so that we can improve Nigeria together. So consider referring all patients with intermittent tonication when you are not sure of their diagnosis. Anybody with critical limb ischemia, which we define as non-healing ulcers, they're having rest pain, they're having dusty foods, and most times they're not doing very well on conventional therapy, on medications. You should refer them to a specialist. This is not patient to manage by yourself.
The patients with diabetes that have new foot ulceration should be managed in the context of a multidisciplinary team. Now, your MDT team is
within 24 hours.
Absolutely. And your MDT team is not fully complete without a vascular person there, so without cardiovascular interventionist there. And especially in patients that have some vascular impairments. So you must assess the vessels, and if there's a vascular component to the foot ulcer, then you must include the cardiac care or other centers when they do intervention for the patients. Now, we know that a lot of these patients may not necessarily require vascularization.
Exactly.
But we should identify those ones that will benefit from that intervention for the limb disease.
Even if you're not having vascularization, there are so many other modalities of treatment. And like I told you, therapies are managed and optimized, based on this together with all of that. So the people that should be vascularized, typically peripheral anatomy, severe quality of life affectation, failure of conservative management, and anybody with critical limb ischemia or acute limb ischemia, you should take them in for revascularization. I'll give you some examples now. So this is what it looks like for the balloon and Doppler. This is just a schematic diagram. In this case, you are looking at when a patient has total occlusion of a vessel. What is happening here is that the wire is going subintimally. So sometimes we have to use a subintimal crossing to be able to go across the blockage. Actually, the blockage is so hard, calcified, and it's so difficult to cross. So we take the wire and go subintimally and come out and then cross it and stent it across. So sometimes this is what we have to resort to in chronic limb ischemia where you have total occlusion, and this will still prevent surgery and save the foot. So you can see in these cases, you can see the vessel before, and you can see this like common femoral, and then you can see with balloon, and then you can see thereafter. Even after this one, you just put the balloon, so you see how to put the stent. So you can see that there's some indentation, so you have not fully opened it up. So then you now put in your stent and you open it up so that it can be smooth like this other one. So we have this case, 42-year-old man, no diabetes or hypertension, lipids were marginally elevated, came in from one of the northern states some years ago, smoking about 12 pack years, some numbness of the foot, progressive dust discoloration of the foot. So I'll just show you the imaging. So this is what we saw on the imaging. This is what we saw on the imaging. I think all of us can appreciate that. Please, if you can put in the chat box what you can see. If you can put in the chat box what you can see, hope everybody can access the chat box. Yes, I think so. If you can put in chat box what you can see in this image, it will be good. But the arrow is pretty clear. Which artery is this? What I'll ask. So from what I can see, it looks like the anterior tibia. And so we cannot forget our anatomy when we come to vascular. So this is what we found in this man. We went on to do, first of all, we do the balloon division, then we inflate the stent. And you can see the stent coming up very nicely. So you can see the balloon coming up. We don't just use a normal sling, we use an inflation device to raise it up. Please, Ogochukwu, let me know when Dr. Dafe is speaking. You need to put that here, please. Okay, so you will put that and then we can see that. So thereafter, we can now see what the blood supply. You can see the stent there, looking like a net, like a stent, and then you can see blood supply is now restored to that place. Now, if you look at the before picture and after, you can clearly see that this has made a lot of difference in the care of this person. Okay, so you can see that. Now, these pictures were taken over 2 weeks apart. So after you do it, it's not as if the next day the person will just start. And it's not always like this. Some cases you open it up, if there's already gangrene, the good thing about it is that you wait some time and then you will see demarcation of the areas that are gangrenous. A clear line of demarcation that the police cannot walk in and see how much they can salvage. This is another case, much more difficult, not like the other one. And you can see that blood supply stops completely in the mid-thigh. Okay? We can see that very clearly. And almost no blood supply when you get to the knee. So you can see blood supply stops here in the mid-thigh from the SFA. And look at the knee. There is no blood supply. Now, by the time we're able to open it up, we can see blood supply going to the knee, but just beyond the knee joint. Okay, so sometimes you are able to open it, and let me show you again. I hope I have access to controls. Not possible. Okay, so you can see that, and even without the contrast, you can see some of the blood vessels. You can see them because of the amount of calcium inside the blood vessel. So this has happened for a long time. So by the time we are doing endovascular intervention and there's already gangrene, like this already had gangrene, sometimes the best we are getting is to reduce tissue loss rather than completely stop anything in that case. Okay, so that is the okay, so 5-year survival is there. Most patients, about 12% of patients with critical limb ischemia will require amputation within 3 months, and 20-25% die within a year. This is quite high, and this is why we need to intervene. Okay, Dr. Dafe, do you have anything to add to these cases?
Yes, sir. So if you can just give me hosting rights, let me share some few cases.
Okay, so go ahead.
Okay, sir. Thank you very much. Great job, Dr. Iseko, Dr. Awofisoye, the great and the greatest man I have ever met. Great guy, great guy. I've learned so much from you guys today. So this is a case of 75-year-old man. As Dr. Iseko and Dr. Awofisoye said, peripheral artery disease affects both the lower limb. They can also affect the upper limb. The upper limb is said to be a forgiving region of the body because it has the lowest risk of atherosclerosis in all the vessels of the body. That is the upper limb. But it doesn't mean that it cannot be affected. I remember Dr. Iseko and I have done intervention for acute ischemia of the upper limb. I think if I'm right, the right upper limb. Yes, now this, yeah. So this case was a 75-year-old man who had a bypass, a triple vessel disease. So it's also the same thing, the same thinking, that a patient who had atherosclerosis in one vessel, there is also atherosclerosis. There may also be atherosclerosis of another part of the body still bearing vessels. So this is a case who had a bypass, and after 4 years, and he started having pain in the upper limb and also pain in the chest. So we felt, okay, that let's look at the graph. That was exactly what happened here. Look at the graph to see whether the graph are still patent. And lo and behold, the left subclavian artery is very critically stenosed, almost 98% stenosis, a proximal segment of it before the lemma was given out. So the question is that what are your strategies in this place? There are many strategies that you can use to reopen this place, but whatever strategy that you will use, one is that you should ensure that you don't block the access of that lemma, because if the lemma is diseased one day, yes, the second have pointed at it. If the lemma is diseased one day, you will have to go back and get intervention to it. And so you will have to be careful with it while stenting. So yeah, that is the proximal segment before the lemma of the left subclavian artery. So what happened here was that you can come from the left subclavian, the left brachial artery. You can cannulate and pass your wire through and do your intervention. You can also come from the femoral, but in this case, the femoral access is already there. So we have to now approach it from the femoral. Now see what happened when we came from the femoral. Yeah, let me just play it. So you see that this is after the stenting. So after the stenting, you notice that we pass 035 wire, pass a long sheet, a braided sheet down to engage the ostium of the this left subclavian. Then with a balloon, it was pre-dilated. Then a stent was displayed, was put, and this is the final result. And after even this, the more flow now came down into through the lemma. So that patient was salvaged. So this is also another case of iliac intervention. Dr. Iseko has shown it before, that iliac interventions are really very complex. But one good thing about iliac intervention is that you can come from the upper limb, the brachial, as a form of brachial access. You can also come from the lower limb. You can also come from the pedal access or the peripheral access. Now, another key thing around here is that if you look at this vessel, this is the adductus hiatus, where the SFA, this superficial femoral artery, crosses and become popliteal. So if you can gain an access around this place and be able to go up and do your intervention, and you can also gain access via pedal and also do your intervention. So this is another case, a case 3, also talking about the iliotibial region. You notice here that this patient has one of the common iliac arteries totally occluded. So this patient was actually having the blood supply to the lower limb via only one common iliac artery. Now that you know, the common iliac artery divides into internal iliac and the external iliac. So the external iliac will continue as a femoral, while the internal iliac supply the pelvic area. So one internal iliac can communicate with the other internal iliac in order to cross cross blood to the second part of the body. That was exactly what happened here. So how do we intervene in this case? So to intervene here is really complex, but see what happened. The first thing here is that we came from the from the ipsilateral. We couldn't really see anything. So what they did, you punch up here under fluoro, you know where the vessel will be. So you can see the puncture is going on there. Yeah, crossing down. Very soon you will see the wire crossing up. So you use the landmark to puncture, and you go up. Yeah, you can see the wire moving up. Then yeah, the wire has entered. Then you can take another puncture from the contralateral. You will soon see it just now coming out. But if you are doing this, you have to have a snare so that you'll be able to snare one wire into the other, so that if you are creating a dissection, you'll be able to know before you put a stent. You can see that we are the snaring process is going on. So we'll take another wire and snare from the opposite side and bring it out. So a lot of hardware goes into peripheral intervention. So this, we have snared this out. Yeah, very good. You have snared it out. So you can be able to track that area and balloon it open, and you see the good result coming out. So you can see that snare there. Yeah, that is the snare. So you snare it out and you get your good results, and you move on with it. So these are people that present with, as Dr. Iseko and Dr. Awofisoye said, critical limb ischemia, acute limb ischemia, especially these are all cases of critical limb ischemia. So peripheral artery disease is, you must send it to the center that has the capability to evaluate and know it. And cardiocare has all that it takes to evaluate such patients and give a very excellent and good result. So you can see that a stent is being, is being displayed here, and you can even create a new carina. Yeah, you can see what is going on here. You can create a new carina if at all you want to put a stent, or you balloon and you see the results and you move on. So a stent has been placed here because these are the point of critical point where the vessel is totally obliterated. So you open it and move on with that patient. So you can see that the stent has already been displayed. This is here, I think, a balloon expandable stent. So the difference is that if you are putting a balloon expandable stent, you should know the size of those balloons properly. If not, if you are doubting the real size, you can just go ahead with your self-expanding stents, which are better, and you don't worry about the size. So this is also another case, diabetic. As we said, we have all the risk factors that were mentioned in the course of the presentation. This patient is diabetic and has pain at rest. See the angio at rest, you can see the angio. So this is the popliteal artery. Now from the popliteal artery, you can see that popliteal artery give rise to the, where my cursor is, that is the anterior tibial artery is almost 99% occluded to 100% occluded. Then you have also the tibio-peroneal trunk, which now form the posterior tibial artery and the peroneal. Yeah, that is the anterior tibial artery, correct. So Dr. Iseko is doing a great job there. So you notice that intervention to the anterior tibial artery, we just ballooned, and we saw that the flow was okay and fine, and the revascularization was fine. So we left it at that point. So these are some of the cases that we usually have from this part of the world. So we should always refer our patient and make sure that our patient benefit maximally from our cases of peripheral artery disease. All the risk factors are there. We should refer them and they will benefit. Thank you.
All right, thank you very much, Dr. Fantastic slides for a lot of cases that we have done here. So we'll take any questions as we are coming, but I'll just try and round up the presentation with this algorithm. So number one, if you look at this clear algorithm, I will share it also to the group. You can join our WhatsApp group so that you can ask questions. You can ask questions even after the webinar, and then you know what the next topic is. And when we share important clinical tools like this, so all patients at risk, especially those above 50 years, should be screened. And the first screening is history. Clinical history and examination is the first thing which is available to all of us. Is there diabetes? Is there smoking? Is there hypertension? Is there dyslipidemia? Are there signs and symptoms that are suggestive of this? So even though there are no signs and symptoms, that we say 50% of these patients are, asymptomatic. You can still see if they have diabetes hypertension. Now, for all diabetic patients and all symptomatic patients, you must examine and you must do an ABPI for them. So if we're talking about symptomatic patients, some of them are even having blackish color with food, non-healing ulcers. For the ABPI, you have three outcomes that can happen. One, ABPI is at 1.4. ABPI is borderline or normal. Or ABPI is less than 0.9. So let me start with greater than 1.4. The greater than 1.4, what you should do next is do a toe brachial index. If you cannot do this one, consider just doing an ultrasound maybe. Now, if you do the toe brachial index and it is normal, like 0.7, then you know that you are out of this thing. Now, if you do the toe brachial index and it's less than 0.7, or you have this critical, you have a non-healing wound, you have gangrene, then whether it is not, then you now have to do the Doppler ultrasound. Now, if the Doppler ultrasound is normal, then you might think that maybe the other thing happened. But in some cases, Doppler also has interest sensitivity. So in a normal Doppler that has symptoms, you should consider, referring to a center to have a full range of tests. But if the Doppler is abnormal or abnormal TBI, then in that case, you should go refer straight to Cardiocare or other center for peripheral angio. Now, for patients with a normal ABPI, with an abnormal TBI or abnormal ultrasound, they should also have a peripheral angio or a CT angio to be able to determine their care. Now, if they have normal or borderline and they have no symptoms, then you can continue your management. However, if they have an abnormal ABPI, so you can see ABPI is at the center of everything. Now, if ABPI is less than 0.9, those between 0.7 and 0.9, please make sure they have an ultrasound done, or you do a toe brachial index if you have the ability to do so. If that is normal, then check other causes. But don't forget to continue to manage cardiovascular risk because this person is not yet free. However, if it is ABPI is 0.7, 0.9, and the Doppler or the toe brachial index TBI is abnormal, please need to go further. Don't wait until you can't have those symptoms to be too late. But if you already have ABPI less than 0.7, then straight you should start with or without symptoms. You should begin to consider more aggressive. I hope this helps in our environment. I see what we need is history, examination, ankle brachial index. You can do a toe brachial index, or you can do a Doppler ultrasound, and you'll be able to know what to do. But in all of them, once you have any borderline or abnormal, make sure that you begin to optimize medical management and cardiovascular risk. So, Dr. Awofisoye, maybe you can just conclude for us.
So it's been a wonderful presentation and the discussions we've had so far today. We know that peripheral arterial disease is live and here with us, and we're missing a lot of it.
Yeah.
Okay. Apart from it being something that threatens to live itself, it's also a matter of ASCVD, and there's a lot that we need to do for these patients. There are always a bag of mix of comorbidities, let me put it like that. And a lot of these patients will require revascularization. A few may not. Now, we do offer the revascularization here in cardiac care multi-specialty hospital, but even the ones that don't require revascularization, they often almost always require a modification in their therapy. And when we're able to give patients the treatment that they require, quality of life is improved, and more importantly, we often reduce the need for major amputation. It's almost always a disaster. Now, we know that patients with diabetes, which we have a high burden of them in Nigeria, they have a high risk of developing critical renal ischemia. I think I'll remind all of us that we should evaluate patients for peripheral arterial disease.
Yeah.
And when we pick them, we refer to these patients for us.
Okay, so you can refer by scanning the QR code, or you can call any of the numbers on the screen, or you can join our WhatsApp group, and we can also just discuss some of the cases so that you know if you are unsure, we are available around the clock. So to join the WhatsApp group, you can scan this. Where is this one? Okay, yes, you can scan this QR code to join the WhatsApp group. If you are not already in the WhatsApp group, if you're not in, you can just scan this QR code, and you'll be able to join the WhatsApp group, and we can answer questions after now. You can discuss cases, but our rule is this: when you bring up a case, attempt to answer the question, then we will now assist in the answer, just to make sure that we are making some progress in building the next level of Nigerian super physicians that are here. Hopefully, most of us are still to be here, not to Japan, but we're here to treat other people. All right, so these are some of our references, but again, this is our summary slide. Consider it when you are taking all your patients. We will send the slides to you so you can use it in your daily practice. You can also rewatch the video so that you can get it, or share it with your team, your clinical team, so that you can get access to it. In the absence of anything, I think we can more or less consider this. Are there any questions? Somebody asked a question. Can renal disease cause intermittent claudication?
I would say not typically, because again, it typically affects the smaller arteries. But that is not something that might be checked up. Okay, but not typically. Typically, renal disease classically presents with pain and discoloration of the fingers, and it can lead to gangrene in the fingers, usually in the hands, also in the feet. Now, it doesn't typically affect medium-sized arteries like those that supply the calf and core, but it's not impossible. So I won't rule it out, but it won't be a typical presentation of it. Thank you very much.
All right, so I will just show you some very interesting cases as we round up, so that we can know what is happening with our disease. So this is a patient. Let me start from the beginning. Sorry about that. So so this is us. We are cardiac care hospital, and we are committed to the medical tourism, which includes education, which includes reinforcing guidelines for Nigeria. And we think that this is quite important. So let's look at some cases, some clinical cases. We had this patient, 52-year-old man, ejection fraction 28%, low ejection fraction with heart failure, came in, this was his echo, and we already saw there are problems. We took him for an angio, which was normal. But his ECG already showed this. Now, if you cannot read this ECG and you're thinking, oh my God, this picture is Jaga, please go to our webpage, cardiocare.net/webinars, and you see the ECG one for Nigeria. You can watch it, and I assure you do the ECG. So we can already see multiple PVCs. And when you have more than 3 PVCs in a row, we call that ventricular tachycardia. If it does not last up to 30 seconds, we say it's non-sustained. If it lasts more than 30 seconds, we say it's a sustained ventricular tachycardia. We can already see that. So what happened next was, while managing, he developed a VT, came unconscious, and we had to issue a shock to be able to get him back to normal. And this tells us that almost all patients with ejection fraction less than 35% in heart failure need some kind of device in their heart. So he had an ICD implanted, heart failure was device, and this is him much later, doing very well. We had this woman again, the old woman referred, palpitations on X-Forge, on drugs, good drugs, with ultrasensorium. This was her ECG from referral center. Again, if you cannot read this, go to our webpage and watch it. You will be able to read it after you do that, I assure you. But this looks like a ventricular tachycardia that is happening. And it can often be life-threatening, especially when the patient was having ultrasensorium. You know that is an indication to intervene. Later on, she had the same thing. When she came, it was normal. Later on, she had the same thing that required a shock. Then, while we were operating to put in this ICD in her heart to prevent her from having it again, He had multiple VTs happening. And you can see this is our reading, our strip showing the VT, and this was a shock. And if you look clearly, you can see shock number 8, 100 joules, and then it comes back to sinus reading. Thereafter, and you can see on the monitor, you can see the VT happening, and the device is in situ. So the device treated her without her having to come to the hospital for that. So now we can see the patient in clinic much better. And remember that all patients with ejection fraction less than 35% and NYT class 2 or 3 not require an ICD, and that is a class 1 indication. So meaning that it's an indication that is really, really important and that has been shown economically to be important to show health. Patients that survive a cardiac arrest due to VF or VT typically meet with death. And this. Now we have a 57-year-old vet that came with heart failure, also had a low ejection fraction. QRS was wide and had multiple heart failure related admission. So if the ejection fraction is low and the QRS is wide, typically they need what we call a cardiac resuscitation therapy. And you can see this was put in by me and Dr. Edafe. And we put it in to give her a very good chance at life. She improved dramatically and was able to use the heart failure related admissions thereafter. Talk about this man, and this is another way to see peripheral artery disease somehow, because now it's happening to kidneys. Strictly speaking, sometimes we typically have to separate peripheral artery disease from thrombosis that happen in other parts of the body. And that's why there's a move from peripheral vascular disease as an umbrella body to lead lower extremity arterial disease, so we can truly separate these entities because their clinical manifestation is different. When this man that came with acute abdomen, he had an urgent CT that showed a renal artery thrombosis, and despite being on apixaban and having a previous ischemic stroke. And so what we did, we could see that there was 100% occlusion, and then what we did was to do intervention for this with CDTT, mechanical maceration. We spent all night in the lab to be able to get post-procedure blood supply to that kidney, and was able to go home.
The kidney was rescued.
And the kidney was rescued. I mean, and of course, after that, we had to change his anticoagulant therapy. Repeat.
I just want to highlight here. So, yeah, catheter is there in the kidney, contrast was being passed, but the kidney cannot be highlighted. So you can't see anything as if there's no kidney there. But now, this after the thrombus was sorted out, and you can see now the arteries within the kidney. You can even see the silhouette of the kidney coming back to life. That's really beautiful.
Okay, we had this 42-year-old with acute submassive pulmonary embolism. Now, we define pulmonary embolism, and we have a presentation of pulmonary embolism on there, which you can learn from. Pulmonary embolism is defined as massive or submassive, massive when there are significant hemodynamic effects happening, with it. So, she had Doppler confirmed DVT, CT confirmed obese, recent long distance travel, and you can see the clots right there. Massive clot, stopping blood flow to the entire left lung. And you can see the left pulmonary artery now, post-procedure. And this is quite important. This will have significantly reduced pulmonary hypertension, reduced debility, right heart failure that will have happened over time. So it's quite important for care in this patient. So what we do is that if you can get the patient in time, especially those with suspecting PE, they are having hypoxemia and they have a low blood pressure, you need to get them to be able to, for us to be able to intervene as soon as possible. We also have to put an IVC filter because the clots were still there, and they presume that there was a recurrent reason for that clotting in this case. This is the case we discussed earlier, and we talked about that. What is a man with chest pain? And we have a talk on chest pain and how to manage heart attack, so you should also try and get that there on our site. So chest pain should always have an ECG. Always, always. If you don't remember anything, remember this. Chest pain must always have an ECG. Don't say it's ulcer. Don't say any ulcer in an adult must have an ECG. Okay, so you can see how we do it. We put it into the into the femoral, and then we come in here. You can clearly see the obstruction here, and it was happening. Luckily, patiently within 12 hours. And so what we do, we put a balloon inside, open it up first, then we put the wire and we put the stent. This is what we use to expand the stent. It's not a balloon. We do this inside the cath lab. The patient is awake, diagnose scars, and they go home the next day. So this is before, and then we can see what it will be after the case, afterwards, and you can see blood supply is remarkably, and patient goes home the next day in that case.
It's an interesting case. A 56-year-old Jehovah's Witness that had a arterial femoral artery injury. I think that happened during cannulation for dialysis, and then the diagnosis was established. Now, the interesting thing here is that the person is a Jehovah's Witness and was not willing to take blood transfusion. This was 12%, whether you believe it or not, it was 12%. And rationally, the vascular surgeons were not willing to do an open surgery because of this PCV and because the patient was not willing to take blood. Unfortunately, there's actually the option of endovascular intervention, which was not previously considered before. We're going to see the video now. You can see the femoral artery was catheterized here. You can see blood spotting out.
You can see it coming out where the arrow is pointing to. You can see it spotting out. And this is us putting the stent across where this blood is spotting out to really position it properly. And afterwards, blood supply has stopped. See before where it was and after, no more blood flow. Luckily, we did this under 30 minutes, and then she was able to go home, go back to the previous hospital. PCV was 12%, so did not want the blood, go back to the previous hospital and be able to get their dialysis and continue therapy. So this is so endovascular care for peripheral injuries, traumatic peripheral injuries, is also arterial injuries, is also an important thing. So this has been happening ongoing, and this patient was losing blood despite being somebody that did not want blood. So it's important for us to know that this is readily available. Thankfully, we now have cardiac surgeries, open heart surgeries all year round. Kidney transplant, we've done 2 cases by the grace of God. We are grateful to all of you that have supported us and that continue to support us. And then we started structural interventional cardiology for children. So in cases we want to close a VSD, AS without open surgery, we just put a device, PDA, the child goes home the next day, and so, and I want to remind you about our cardiovascular symposium. The 7th one is coming up. First week of December, 7th ACS is coming up. Don't miss it. Make sure you're in Abuja. 7th ACS. Mark your days. 10 CME point. This is one of the meetings that we've had. We're going to be moving stuff live and basic life support. We're going to be focusing on algorithms and SOPs for care. Just SOPs. What do we do next? Sometimes we have moved so much stuff, we don't know what to do next. Now, simple thing that you can easily take home and scale. So that's what we're going to be doing next. This Dr. Alekon is not with us today. He's downstairs seeing patients. This Dr. Awofisoye when he was much skinnier, and this will be when I was also skinnier. And of course, we had the national interventional at the process. You can scan this to refer or get any of the numbers. I'm very happy to have you. I'm very happy to have been part of this, Dr. Awofisoye. Thank you for joining us.
Thank you so much.
Dr. Dafe, thank you for joining us too, if you're still on. And I think we have answered all the questions on it.
Thank you very much.
Yes, thank you too. So you can get the video on our page on cardiocare.ng, and you can also get it on our YouTube channel. And the link will be sent to your emails. Also, the slides will be sent to your emails so that you can share it, and we can get better as a country.
Okay. I think one doctor at a time, one patient at a time, one center at a time, we can all improve the healthcare landscape and what we deliver for our patients in Nigeria.
All right. Thank you very much. Have a lovely day and have a lovely weekend. If you're in Abuja, please join us for the Abuja Health Walk tomorrow. We are doing free CPR training. So you can join us, and then you can join us and walk. Let us practice what we preach. So thank you so much for having us. Have a nice day.
Thank you very much. Have a wonderful evening.